Okay. Dr. Didman, you can start with the indication and other pre-op preparations.
So, Dr. Ruplekha,
Good morning, sir.
what do you mean by low anterior resection?
Low anterior resection means sphincter preserving proctectomy with total mesorectal excisions and R0 dissections.
How is it different from anterior resection?
Sir, anterior resection can be high anterior resection, low anterior resection, ultra low anterior resections. In low anterior resections, we use we do the rectal tumors where 2 centimeter away from the anal verge. That is, from the tumor, we can preserve at least 2 centimeter distal margins.
No. What? Depending on the site of rectal resection, you have peritoneal reflection.
Yes. Sir, in case of high anterior resection, we will do when the tumor is at rectosigmoid junction and at the upper rectum, where we will do the partial total mesorectal excisions. Or in case of low rectum.
When you are above the peritoneal reflection, it is generally anterior resection. If you have gone below and you are not having to do an abdominoperineal resection, you are being able to preserve the sphincter, then you are doing a low anterior resection. Now, what are the margins and all? We will come to that. We'll discuss that later. What are the indications of low anterior resection? You have said already.
Yes, sir. The rectal CA, where the tumor is at least 2 centimeter distal margin, we can safely available.
Mid-rectal CA, where in spite of taking 2 centimeter intraluminal margin and 3 to 4 centimeter margin in the mesorectum, you can still preserve the sphincters. Okay.
Okay, sir.
How do you prepare a patient for? Is there any specific steps of preoperative preparation that you must do before taking the patient for surgery?
Sir,
first you tell me what are the preoperative investigations must do to plan a low anterior resection, and then how do you prepare the patient preoperatively? Both things very quickly.
Okay, sir. Sir, after confirming the diagnosis, I will do the full-length colonoscopy examination along with the CT chest, CT abdomen, and CT pelvis, and MRI pelvis in case of the lymphovascular invasion or metastatic disease and the rectal growth, invasion of the rectal mass to the rectal wall.
What kind of MRI?
Diffusion-weighted MRI.
Contrast enhanced MRI you may do or whatever with an endorectal coil, a dedicated endorectal coil, because you need to see the depth of involvement of the rectal wall also. Otherwise, you won't be able to decide which patient needs neoadjuvant therapy and which patient does not. Apart from that, there is importance of assessment of the lymph nodes. Minute criteria are there, like size of the lymph node. What is the significant size for a lymph node in the mesorectum? 9 millimeter. For the lateral lymph node, 7 millimeter. Okay, so minor things can be picked up by MRI, and on the basis of that, you can decide about neoadjuvant therapy if needed. So, what are the indications of neoadjuvant therapy? And in which form? Why do you give it? I mean, you may get
any lymphovascular invasion or any metastatic diseases patient, or in case of T3 to T4 lesion to downstaging to avoid the abdominoperineal resections, for sphincter preserving surgeries, we will give the neoadjuvant chemotherapy.
What do you mean by sphincter preserving surgeries? What are the various options of sphincter sparing surgeries, apart from the one we are talking about?
So, in case of supraanal, there is a classification: the supraanal tumor, juxtaanal tumors, intraanal tumors, and transanal tumors. So, in case of supraanal tumors, we will do the lower anterior resection. Besides this, we can
not tumors, procedures.
Procedure, and then we can do the intersphincteric proctectomy, and or we can do the partial intersphincteric proctectomy or total intersphincteric proctectomy.
And transanal procedures,
transanal
endoscopic, microscopic surgeries, so many are there. Okay, so you could not clearly say the indications of neoadjuvant. Neoadjuvant is for locally advanced rectal cancers, where you doubt that you will not be able to take a margin if you are doing sphincter preservation there, or even T1 or T2 if there are lymph nodes.
Lymph node invasion.
T3
To
with a
downstairs.
threatened mesorectal margin, like where you anticipate there could be involvement of the mesorectum. So these cases you will give neoadjuvant therapy. So what kind of neoadjuvant therapy will you give? What is the current consensus? Previously, we used to give short course radiotherapy and then we would operate the patient, or sometimes we would do sandwich therapy, chemotherapy, short course radiotherapy, chemotherapy, and then operate the patient. Or we would do long course radiotherapy along with part of chemotherapy and then we would operate. Now it is said you should do total neoadjuvant therapy, achieve as much response as possible, and then take the patient up for surgery. So what are the chemotherapeutic agents? You know?
So for Folfox, Folfiri.
Good.
Regimens.
Okay. So the patient has received neoadjuvant therapy, or if it is an early case, you have decided for surgery. Now, how will you do preoperative preparation?
After doing the investigation and PSC fitness, we'll admitted the patient. We'll give the high carbohydrate loaded supplements 2 to 3 days to replace the lost.
As per
ERAS protocol.
ERAS protocol. Mention that thing. Then somebody can ask you what do you mean by ERAS? Okay. So as per ERAS protocol, you will load the patient with carbohydrates. Apart from that.
Apart from that, sir, mechanical bowel preparation done.
How helpful is mechanical bowel preparation? Is it mandatory?
Sir, according to ERAS protocol, it is not mandatory now.
Then why would you do it? For your convenience. For your convenience. You do it for your own convenience to prevent, if there is, by chance there is breach, then there will be soiling of the entire operative field. It will be difficult it will make your life difficult. So you
and in our patient population, most of the our patient has loaded colon. So most of the time now people are saying that bowel preparation is part of care. ERAS protocol is not there, but most of the people prefer to do bowel preparation.
It is to keep the operative field clean, because if you operate with a loaded colon, it's difficult to handle the bowel also. And there is all the debate is about mechanical bowel preparation, but you're also using antibiotics.
Prophylactic injectable antibiotics. Liquid diet it allowed 2 hours before the surgery, and according to the ERAS protocol, we can give the venous.
Not liquid diet. No, not liquid diet. Clear liquid. You cannot allow milk as liquid diet 2 hours before surgery.
No. Clear liquid is allowed.
Clear liquid.
So read every word with caution. In a book, when there are 2 sentences, there are so many keywords. Clear fluids is a different thing altogether. Okay.
And then a mechanical or pharmacological venous thromboembolism prophylactic, or prophylactically NSAIDs will given, anti-opioid agent can be given for better patient.
About preoperative blood transfusion.
So preoperative blood transfusion is needed according to the level of hemoglobin.
I mean, if absolutely needed, you may have to, but unnecessarily,
you will not do it.
I mean, if it is 8, you do not target a preoperative level of 10, because preoperative blood transfusion in colorectal cancer is shown to induce immunogenic response and alter the prognosis of cancer.
Yeah.
Okay. Next.
Not only pre-op, perioperative transfusion is also taken as one of the prognostic factor.
Besides that, sir, in case of anesthesia perspective, we will suggest the TAP block, transverse abdominis block with long anesthetic agents, or we will give the epidural anesthesia.
What will be the position of the patient? Anesthesia done. You can do the surgery. Do you need always general anesthesia? You can do the surgery under epidural anesthesia. Also, if you are planning to do with the lower abdominal incision. However, if you are planning to do laparoscopy, it's better to obviously do under general anesthesia.
So the positioning of the patient is modified lithotomy position or Lloyd Davis lithotomy position with padded stirrup.
Sir?
Sir, in case of that, in the lithotomy position, patient is present in the tenderloin position. And then after anesthetic scraping and draping, we'll give the incision.
Make the incision. What incision will you make?
Sir, it will be a vertical lower midline incision from the
Low midline means below umbilicus. Try to understand. Sometimes below umbilicus incision may not be enough. You might
also
need
3
to.
centimeter above the umbilicus to the symphysis pubis.
Any other incision that you can employ? And the problems of such incision?
Sorry.
Paramedian incision, what is the problem of paramedian incision?
In case of paramedian incision, sir, to enter into the abdominal cavity will be difficult. Or if there is any history of previous surgery, so
it weakens the abdominal wall, no? I mean, you're cutting the muscle and going through.
Yes, sir.
Okay. Okay. So now you have entered the abdomen. Now you discuss the steps in details.
Divide the steps into salient points and describe.
Sir, after entering into the abdomen, the first thing is the examinations of the abdomen, thorough examination of the abdomen, presence of any ascitic, to check the presence of any ascitic fluid or not, to check the liver metastasis, to check the momentum, peritoneal metastasis, and to check the rectal growth, the extension, if the sphincter is involved or not. Then we will do the exteriorization of the small gut. Small gut is delivered out of the wound, and
there are two things. Yes, once you explore, one is assessment for distant metastasis, and second is assessment for resectability.
Yes, sir.
Regarding resectability, what do you assess?
So
suppose you are operating on a male patient.
So the size of the tumor, extension of the tumor, whether it is involvement the bladder, seminal vesicle, prostate, or whether it is involved the ureters or not, the sphincters are involved or not, if it is turned into the APR or not, will it feasible to do the LAR procedure or not?
If there is hydronephrosis in preoperative imaging, what will you do prior to surgery?
So degestenting will do to preserve the ureters.
Preserve, no, to identify
the
identification of the ureter during surgery. Okay, I mean, suppose there is hydronephrosis, then you have given neoadjuvant chemotherapy. Even then, hydronephrosis can persist because maybe the cancer will respond, but desmoplastic reaction is there, and the ureter may be encased by that fibrosis. So you have to do a degestenting to identify the ureter during surgery. Okay. So now you have identified there is no intraperitoneal or intra-abdominal metastasis anywhere else, and you find that the tumor is resectable. So how will you proceed?
Sir, at first we will deliver the small vial out of the wound or packed it up upper abdomen.
No, do you deliver the small intestine always outside the abdomen for operating on?
Sir, we will do the packing.
In the upper quadrants.
Doing the tendon positions, it will move outside.
You pack it off outside the operating field.
Then at first we try to the mobilizations of the sigmoid colon and the descending colon.
How?
So it can be done in two ways. It can be from medial to lateral approach or lateral to medial approach.
You answer one. For example, you answer one. You start describing, you said mobilization of the sigmoid colon. Start describing the step. The next point is sigmoid mobilization. Why do you start?
Sir, we will start from the lateral pelvic wall along the white line of Tolt in the avascular plane.
In sigmoid, you don't find Tolt line.
Sir, we'll do it to the lateral pelvic beam. We will dissect the
sigmoid mesocolon has two leaves.
From the lateral.
Sigmoid mesocolon has two leaves. Sigmoid mesocolon has two leaves. Left leaf and the right leaf.
Yes.
Why do you first put the incision at the apex
sir,
of
we'll
sigmoid
do it
mesocolon?
The left leaf.
Okay, fine. Apex of sigmoid mesocolon.
Yes, sir.
What you take care when you make the incision and start dissecting?
Sir, in the apex of the sigmoid mesocolon, there is a structure called ureter. We will identify it and we'll try to preserve it.
Okay.
And then we'll dissect it up to the up to the splenic fixtures. And after completing the dissection on the left side, will go to the right side, and the right leaf of the mesocolon is dissected from the retroperitoneal structures.
Hey, I mean, you have to proceed downwards. You are doing an anterior resection.
Sigmoid mobilization. Next is what?
Yes, sir.
Sigmoid mobilization. Next.
Next, we'll do the mobilization of the descending colon, and up to the splenic flexure. Splenic flexure is mobilized if
What you have said, you have done.
There is a concept of early division. There is a concept of early division of vascular pedicle.
Yes, sir.
Once you start with sigmoid, what happens?
First, there is first we will dissect the inferior mesenteric artery at the beginning of the aorta to take the lymph nodes dissection, and we divided the inferior mesenteric artery and ligated it at the level of the left colic artery, preserving the left colic artery.
Do high ligation, preserving the first.
Yes, sir.
Some surgeons say you can sacrifice that also.
Yes, sir. High ligation can be also done. And during the high ligation, we will have to preserve the nerves. Sympathetic nerves are present at the level of the origin of the IMA. After that, sir, ligation of the vascular pedicles, we will gaining the adequate length, and then we'll mobilize the rectum.
How?
Mobilization of the rectum and along with the mesorectal dissections. In mesorectal dissection, there are 3 steps: the posterior dissection, lateral dissection, and anterior dissection. In the posterior dissection, we will dissect along with the fascia propria of the mesorectum, and between the presacral fascia and the fascia propria. Through the loose areolus tissue, we'll do the SARP dissection.
What's the name of this plane? Bloodless plane of Hild. Hild. H-A-L-D. Bloodless plane of Hild. Okay. Previously, there was a surgeon, very famous surgeon called Golliger. He used to say that you haven't operated adequately for C rectum if you have not made the patient impotent. But that concept changed over ages. And Hild came out with the concept of holy plane or avascular plane. The plane you just described in between the fascia propria and the presacral.
Along the curvature of the septum and the coccyx, and then we enter into in front of the anococcygeal raphe by dividing the fascia wall layer, which connecting the presacral fascia with the mesorectum, and reach up to the pelvic wall. After the posterior dissection is completed, we will move from the posterior midline to along the lateral sides. In the lateral sides, we will retract it in case of the left lateral dissection. We will retracting the rectum right side, and then the lateral ligaments are stretched out, and we will divide it sharply. And during the dissection,
what are the structures that are present in the lateral ligaments?
So during the dissection, there can be middle rectal vessels, which can be injured and can be sacrificed.
How frequently do you find the middle rectal vessels? 20% cases have middle rectal artery. Okay, then.
Then the
structures are there in the lateral pillars. What do you mean by the lateral pillars? What other structures are there? Important nerves?
Sir, sympathetic nerve chains and the middle rectal vessels and ureter.
Okay. Any other nerve? Okay. Then
after completing the lateral dissection on the both sides, we will do the anterior dissection. It is different for female and female. We will incise to check the peritoneum.
First describe for male.
Okay, sir. Incision is given on the peritoneum, lining the rectovesical pouch, and then the incision is extended laterally.
What is the incision? Try to understand. You already have peritoneal incision on the lateral side. You already have incision on the lateral side. So what you do? You just meet these two cut margins.
In both sides.
You continue these cut margins.
Yes.
Okay.
Then the posterior leaf of the incision is hold with the long hemostatic forceps, and we'll dissect the mesorectum along with the denonvillous fascia.
What is
from
denonvillous fascia? What does it connect?
So denonvillous fascia is the anterior extension of the mesorectum. It connects the rectum along with the
Prostate, apex of the prostate.
prostate.
Okay. So
Yes.
where can you, I mean, in this anterior dissection, where can you experience bleeding from? You have to be careful about bleeding while doing the anterior as well as the posterior. I mean,
Yes.
while doing posterior dissection, if there is bleeding, what will you think and what will you do?
So in the posterior dissections, so
You may have,
Bleeding can happen from where? You have sacral foramina.
yes,
And what
sir.
exists through the sacral foramina?
Sir, inferior mesenteric
No, no, no.
dilation of the aorta to the common iliac.
No, no. There is on the lateral side. If you're in the sacral bed, there are some vessels deep to this fascial layer.
Presacral layers, there are sacral vessels and the
astray, yes, if you go astray and if you breach the presacral fascia, you may end up damaging the presacral venous plexus or plexi.
Yes.
So how, I mean, and there will be torrential bleed. How will you manage that bleeding?
So that bleeding is difficult to manage.
So how
First,
do
you have to manage somehow. You have
You
to
will
pack
not
first.
allow the patient to keep bleeding. You have to do packing. I mean, if you try to take suture, there will be even more bleeding.
Yes, sir.
So
We'll
packing. Okay. When you come to the anterior aspect of dissection, where does it commonly occur from?
You said welder fascia. If you breach the fascia, go more anterior to the prostate, which vessel may get injured? And really, there is a prostatic venous plexus. Okay. Again, it's a very difficult area to control bleed.
Because it is deep in the pelvis. So you have to be, careful.
Yes, sir.
Prevention is better than. Once bleeding starts, it's very difficult to manage. Okay. So next, you are mobilized. Then now you will palpate to see where the tumor is.
Yes.
You are not doing abdominoperineal resection that you will go down, down, and down. You have to stop somewhere. So how will you decide when to stop?
Sir, after the total mesorectal excisions, at least 2 centimeter margin is available from the distal tumor margin. We will stop the dissections and we will do the anastomosis, resection anastomosis.
Our aim is, like for macroscopic margin, we have to have at least 2 centimeter within the lumen, and in the mesorectum at least 3 to 4 centimeters. Now, in the process of taking those 3 to 4 centimeter margin in the mesorectum, for a lower tumor, you may reach the bottom of mesorectum, where it is, kind of inserted like a flower vase in the levator ani muscles. So you can go beyond the the bottommost extension of the mesorectum. So then it is fine. You just take that part. However, sometimes the tumor may be located in such a position that taking 3 to 4 centimeter within the mesorectum, that in spite of taking 3 to 4 centimeter within the mesorectum, you will not reach the bottom of the mesorectum. So there, in those cases, you have to transect through the mesorectum.
Okay, sir.
Okay. So 2 margins are important. One is distal margin and one is circumferential margin.
Okay.
Okay.
Okay, sir.
Okay. So next.
Now you said you will do the distal transection.
How
you have to be very careful. You said you take 2 centimeter or sometimes you need to do 1 centimeter. When you plan to occlude the distal part of the rectum, what precaution you should take?
And how do you transact?
You have mobilized, na? You try to understand. Once you mobilized, the length is gained.
Yes,
so before you apply the clamp or you fire a stapler, what you should do? Or ask the assistant to do? You should do a parectal examination. Okay. So you see how far you are from the anal verge, whether you can safely apply a clamp or you can fire a stapler. Okay, because otherwise, if you do it blindly, you may end up being
The
very close
stapler
to
on
the.
the tumor. Yes.
Yeah. And
What
sometimes
kind
some
of
people
stapler?
suggest that you can do a endoscopy also. Some people say that you can do a
On table.
endoscopy, illuminate this distal rectum, and you apply the clamp, because this is very important. Because if you
So
apply a stapler and you are very close to the tumor margin, it is difficult to do resection.
So in transanal mesorectal insection, we will do the that sigmoidoscopy to ensure the safety margin.
Layer also, it is advised if you have endoscopy facilities to do on table endoscopy, colonoscopy. Okay, you see, and then you illuminate the site
Yes.
of tumor. So if you send light from within, you can see where it is exiting from. From the surface also you can see, and accordingly you can put the stapler. So what kind of stapler you use?
Circular staplers.
For transaction?
No. For transection.
For transaction, linear staplers. Sir.
No.
What is the difference between linear stapler and cutter?
Yes,
you
sir.
got my point. There is a difference between a linear stapler and linear cutter.
Yes, linear cutting step.
No, difficult.
See,
Unless you have a endo. If I have endo use, otherwise it's difficult to place a open linear cutter in the pelvis. The better is you said rightly, it's a linear stapler, T stapler.
TA, huh? Thoracoabdominal right angled linear stapler.
The difference is, what is the difference? Ruplekha? Linear stapler only staples. It does not cut. Okay. So apply the linear stapler, and once you fire it, the rectum will get occluded. You have to apply a intestinal clamp towards the proximal side. And then incise. Got my point? Linear cutter staples and cut. Linear stapler only staples.
And what is the shape? It is right angled.
Okay, sir.
Have you seen one linear TA stapler?
Yes, sir.
It is right angled. And especially now, there is something called a contour linear stapler or contour right angle stapler, which is designed for use in the pelvis. Because in male patients, the pelvis is very narrow. It is very difficult to apply the stapler. Yes. Most of the times we do the mobilization, try to pull the specimen as much as possible and try to apply the stapler beyond that. But even then, it is difficult to maneuver the stapler in the depths of the pelvis. So you have now, sir has told that you will apply the linear stapler, then put a clamp proximally and cut in between. So distally you have cut, proximally also you will cut and deliver the specimen. Now, what is the step of anterior dissection in case of females?
Sir, in case of females, we will excision is extended along the peritoneal reflections of the pouch of Douglas, and then the posterior leaf of the peritoneum is put hold with the hemostatic forceps and put it upwards and backwards, and then we the non-velar fascia along with the mesorectum is separated from the lower third of the.
In females, I don't think it is called a non-velar fascia. Rectovaginal pouch. Then, what is TME plus in case of females? Sometimes you take the posterior wall of the vagina also, along with the specimen. Then it is called TME plus. Okay. Okay. Now, how will you restore continuity?
And again, how do you mobilize the splenic flexure? While doing a low entry section, if you just take the peritoneum up, it will not be easily coming to the pelvis.
What so sometimes you have to divide the splenocolic or rhenocolic ligaments to dissect. Divide it.
So you divide splenocolic and rhenocolic ligament, and then you have to bring the splenic flexure down. So you have to also divide part of the greater omentum. Okay, because this mobilization is important. Unless you can bring this proximal colon easily to the pelvis, it will be difficult to do a low entry section. So this step is also important. Laparoscopically, this is very difficult step.
Because your anastomosis has to be tension free.
Yes.
If there is little bit tension on the anastomotic line, it will break. It will break down. So to ensure tension free anastomosis, the step that sir told is absolutely important. And do not think that it is being done last or being spoken about last, so it is an unimportant step. Okay.
How do you divide the proximal colon?
Sorry, in proximal colon, we will
how far you will go? Suppose you are doing a low anterior section. How far in the colonic transection you will go? Where?
So 5 to 7 centimeter from the proximal margin of the tube.
So usually, suppose 5 to 7 centimeter. If you are in the so you divide only the distal sigmoid, or you divide the sigmoid at what level?
So we divide the sigma the rectosigmoid junction.
No, rectosigmoid will be very close.
Sorry, sir. We are with descending colon and the rectosigmoid junction.
No. You see, if you are doing a mid-rectal growth, a transection the middle of the sigmoid will be good enough.
Okay.
Because you get a good length of the colon also, and you are quite higher up, more than 7 centimeter from the growth.
Yes.
Okay.
How do you transect? You use again a linear stapler or cutter here?
Yes,
Is it
sir.
necessary? No.
No necessary.
Why do
Not
you waste?
necessary. We can do it as sharp dissections with the.
See, I mean, you will need the lumen to be open to put in the anvil and then the purse string.
Yes,
So
sir.
in any case, I mean, why waste a stapler? You apply clamps and cut. Even if you put a stapler, you have to cut that open, because you will have to put a purse string and then put in the anvil, tighten the purse string.
Yes,
So
sir.
proximal end, you will need it to be open. So why put a stapler? Okay, no, I mean, we're wasting resources, but you may do. It's not obviously mandatory to do. Okay.
Yes,
Now
sir.
for the distal, so proximal, I've said proximal, you will put in the purse
Anvil,
string,
and we'll take the plastic
tighten.
switches around the anvil. And distally, sir, we will enter the handle of the stapler through
Before
the
that, you see, you have to clean the
through the
rectum.
fasting
No.
switches.
Distal, perennial surgeon. Now you are going. You should irrigate the rectum stump with a betadine solution, so that rectum become clean. You have close the distal rectum. So before you push the stapler, you can clean the rectal stump.
Okay.
Okay.
Then we'll take a fasting suture around the rectal stump and.
No. Why do you take
You are
rectal stump
doing
first?
layer. Why will you do fasting there?
That is for open. Got my point, na?
Yes, sir. For open, sir. Open.
No, that ও বলছে anal opening এর পাশে purse string নেবে, that is for anal. কোথায় বলছে purse string? When did you just say you will take purse string?
You don't need a purse string. Rectal stump is already closed.
Okay, sir.
You have cut with stapler, na? So rectal stump is already closed.
Yes, sir.
Proximally, you have put in the anvil, you have applied purse string sutures at the anvil, that is done. Now you have the anal opening. You will push the guard.
Enter the handle to the anal opening, which pierces the rectal margin.
Yes, and then you have to rotate the knob at the end. ওখানে লেখা থাকে close open. So you will open the knob so that so
the approximation is possible.
The spear perforates the rectal wall. Where will you?
Where should you preferably perforate? Anterior or posterior?
It's anterior.
No. There is a risk of your bladder coming up.
Rectovesical fistula হয়ে যাবে.
You preferably perforate through the posterior. Avoid the staple line.
এগুলো বলতে হবে যে I will not perforate through the staple line. I will be at least 1 centimeter away from the staple line and perforate through the posterior wall. হলো, এবারে তোমার এদিক থেকে স্পিয়ারটা ঢুকে গেছে, ওদিক থেকে অ্যানভিলের এন্ডটা আছে. So what will you do? You will
engage it.
You will engage the spear and anvil or lock them.
And how will you feel that engagement is done? Once you push, what will happen?
Sound. Click
there
sound.
Is a clicking. There is a clicking sound.
Yes.
তাহলে হলো, এবারে কি করবে? এবারে নবটা যেটা পেছনে আছে ওটাকে ঘোরাবে ক্লোজ,
Close.
ক্লোজের দিকে। ঠিক আছে, এবারে ক্লোজ হচ্ছে একদম ফিঙ্গার টাইট করতে হবে, দিয়ে দেয়ার উইল বি আ সিগন্যাল, ওখানে দেখবে গ্রিন হয়ে গেল, দেয়ার ইজ আ মার্ক স্লট থাকবে, সেখানে গ্রিন হয়ে গেল, মানে ইউ হ্যাভ ক্লোজড ইট টাইটলি এনাফ। দেন
Then fire.
ফায়ার কি, দেন ইউ উইল রিমুভ দ্য সেফটি ক্যাচ,
Okay, sir.
দেন ইউ উইল হোল্ড ফর 30 সেকেন্ডস। আগে তোমার পুরো ক্লোজ যখন করলে, ফিঙ্গার টাইট হলো, তখন 30 সেকেন্ডস ধরে ইয়েটা সেফটি ক্যাচটা সরালে, দেন ইউ ফায়ার and hold it for 30 seconds again to give pressure, so that if there is any bleeding, that will be controlled, edema fluid thakle that will be displaced from the tissue, and the anastomosis will be secure. Then hoye gelo, tarpore then you
What
release
is next?
the pressure.
What is leak test? How will you do leak test?
So hydropneumatic.
What hydropneumatic? What you do?
Sir,
Have you seen
just
people doing leak test? What
no,
you do is, you have done the anastomosis in the pelvis, you pour saline in the pelvis.
saline water into the pelvis so that the anastomosis is within the saline water.
Yes, and then
the
push.
intestinal occlusion clamp is given to the proximal side of the from the into the colon, from proximal to the anastomosis line.
Yes.
And airish syringe is taken and air is pushed to the anal canal.
Yes.
Into the
So
rectum.
look for any bubble coming out.
Yes, air bubble coming out or not.
Okay.
ওখানে আরেকটা স্টেপস আর একটু বাকি ছিল, তাহলে তারপরে গানটাকে রিলিজ করলে, you know, if the handle of the gun you release, then you apply the safety catch again, partially open, and then by rotating movements you take out. Then what do you do? How do you know that the anastomosis is secure? একটা তো লিক টেস্ট হলো, আরেকটা ওটা
What is there in the gun now? What is there in the gun?
ডোনাটটা দেখতে হবে তো।
Yes, sir, to see the two complete
donut, whether there is 360-degree donut or not.
Donuts, two complete donuts is present or not.
Yes. And what do you do to the donuts? Throw them away. You send them for histopathology. Okay, you preserve the donuts and send them for histopathology. When you send the entire specimen for histopathology, do not forget to send the donut also.
And keep in mind that you have to level the proximal donut and the distal donut.
Yes.
It is unlikely that the proximal donut will be positive. Okay, distal donut is more important.
Okay, sir.
Okay. Then
Sir,
এবারে না ঠিক আছে, এটা হয়ে গেল। Now do you always do a diverting stoma, ileostomy?
so no sir, always will not do the diverting ileostomy.
When will you do it? Suppose patient has received neoadjuvant chemoradiation. Patient has received neoadjuvant chemoradiation.
When I have a doubt that our anastomosis is not doing well.
That is one. Yes, that is one.
How can you assess the vascularity? How can you assess the vascularity of the anastomosis at this stage? Yeah, make it out of the box. You can inject ICG and you can see the area of anastomosis under infrared camera and see how the perfusion is. Okay.
Yes.
Apart from that, all the standard predictors that you have for an anastomosis to fail, if those are there, then you may do a protecting stoma. Okay.
Yes.
What is said about a stoma? Does it prevent anastomotic failure?
Sir,
it is said that the diversion
reduce the incidence of anastomosis.
No. It does not reduce the incidence of anastomosis. What it does is, if there is a leak, lest there is a leak, it makes management of the leak easier. Because of the diversion that you do, even if there is a leak, the leak will be less disastrous. Okay.
Okay.
Okay. Now, what are the differences between lap surgery and open surgery? Salient differences in steps.
Sir, in laparoscopic surgery, we will do the ports at 12 millimeter one
ports to hobby. Into difference, principally, what is the difference between open surgery and lap surgery? In lap surgery, you start the dissection from medial aspect and go laterally. Identify the ureter. And in case of open surgery, we go from lateral to medial. Yes, we can. Even in open surgery, we are doing medial to lateral. We are doing early ligation of the pedicle. But this is the basic difference between lap and open. Okay.
Okay, sir.
What is the current status, Dupleka, regarding the lap versus open? What is the current status for laparoscopic colonic resection for cancer?
Safety wise, oncology wise, complication wise, whenever you are asked comparison between open and lap, first of all, you will take up the procedural advantages, like how much time it takes, how much blood loss is there, how much time patient takes to get back to normal life. These points you will say. Next is whether it is oncologically safe or not, whether leak is more or not with open and lap. Even if you don't know the answer, you ask these questions to yourselves and use your logic, common sense to answer.
Recent publication has shown what? Recent publications are in favor of lap, or lap is inferior to open.
Sir, in point of oncological view, there is no difference between the lap and open surgery. But in case of safety during the procedures, lap surgery is superior to the open surgery.
Safety means? No, it's not question of safety. Open is safe. Open is safe, but lap has other advantages.
Less blood loss.
Yes, sir. Less blood loss and during
less pain, early return to work. Okay.
Yes. Yes, sir.
Cosmetically better.
Can you name one oncological surgery that recently is being said that laparoscopically it is inferior to open?
Yes.
Gynecological procedures, radical hysterectomy that they do. Now, recent studies, according to recent studies, they are saying it is inferior in lab. I don't know why this bias is there. Could be due to the surgeons anyway.
Okay.
Next, post-operative management, sir.
Yes.
Post-operative care.
We have done a diversion stoma and this low anterior section. Most of the people will prefer to do a diversion for low anterior section. If you do a standard anterior section and patient is otherwise preserved, routine diversion is not done. But for low and ultra low, most of the people will prefer to do a diversion. Okay.
Okay, sir.
Post-operative
management, sir.
Day 1, day 0, day 1, day 2 এরকম করে বলো কোন দিনে কি ইম্পর্টেন্ট জিনিস করবে
sir, in day 0, in the day in the evening of the post-operative day, we can allow the clear liquids and
if you go by ERAS protocol,
yes,
you mean ERAS protocol, you allow in the same evening. Otherwise, if you go by standard,
sir, it will be 48 hours.
Patient IV fluid, antibiotic, analgesics, PPI. So these are standard post-op. Patient apply a stoma bag.
If anesthetist has put in a Riles tube, will you continue using the Riles tube? Is there any benefit?
No, sir, I will not.
Remove it at the end of procedure.
Remove.
No, sir.
Catheter has to be there. Keep in mind.
Well,
because we have done pelvic dissection, you have to keep the catheter and see whether the patient can sense in the post-op period. Okay. So,
nerve you haven't talked about. Nervi erigentis. What is nervi erigentis? Where do you encounter it? During surgery, you haven't talked about it. This question is asked, what are the different nerves and plexi that, ganglions, etc. that you encounter? To start from the sympathetic chain, you have to talk about hypogastric plexus, all the plexi. Do not forget, when you said lateral pillar, you have talked about the pelvic splanchnic nerves, the nervi erigentis. Everything has to be mentioned, and where, if you are asked where you will encounter, you have to be able to say. Okay.
So nervi erigentis is the parasympathetic plexus of the nerve, that help in the erections of the.
Anyway, now we'll talk
So
about the post-op.
at what point you find this? When you divide the lateral ligaments, the nerve agents may get injured while you divide the lateral ligaments of the rectum.
Yes.
I asked you twice what you encounter in lateral pillar. You just said middle rectal artery, but that's in 20%. That is not of concern also. Of concern is this. Because, you know, if you render a 45-year-old patient impotent nowadays, it will definitely lead to a medical legal problem.
Yes.
Okay.
In case of post-op management, sir, we will put the catheter 3 to 4 days post-op in post-operative period.
Suppose
And
the patient starts having ileus tachycardia again on the 3rd, 4th post-operative day. Now, what will you do?
sir, in case of ileus or tachycardia, we will suspect the anastomosis leak and we'll do a CCT examination.
CCT
So ensure my diagnosis. Sir.
Rule out, you know, hypokalemia, etc., and then you do a CCT to assess whether there is any leak or not. Suppose you haven't done a diversion and there is a leak. What will you do? Low anterior
Sir,
resection
it will depend on the amount of the leakage. If it is a small in amount, there is no peritonitis is created. We will go for a percutaneous drainage and give the antibiotic and wait for some days.
Large gut, large gut. When it is low anterior resection, it is a large gut leak. It is better to intervene early.
Reopen.
It's SCCME, we had an entire session on this. Sir, I'll ask sir to
Yes.
add his comments.
If you have not done a diversion, you should go for early diversion because a large gut leak is all full of bacteria and patient has got early systemic sepsis. So in that case, diversion is important. And if you have a drain placed in the pelvis, if his drain is functioning well, keep the drain. If they feel the drain is blocked, you can reinsert a drain. Okay, early intervention is important. Okay.
Okay. Sir.
There is no role of being, trying to be conservative in this. Okay, so what do you mean by early stoma reversal?
Sir, in early stoma reversal, it will suspect that there will be any mechanical injury.
No. You don't get the point. You have done a stoma, and this stoma usually you close by 8 to 12 weeks. Now there is a concept for early stoma closure. In this case, why you have done the stoma? To protect the anastomosis.
Yes, sir.
How early you can close it? Now suppose the patient, the anastomosis is healed. Patient is passing stool flatus. Stool to hobe na diversion kora ache jai hok mane you see that the anastomosis is healed. So how early can you close it now?
So 4 weeks.
4 weeks, maybe earlier also. Okay, if the anastomotic site has healed well, you do a contrast study, you see there is no leakage. Okay, in that case you can close the stoma as early as 2 weeks. So early closure is between 2 to 4 weeks, because idea was why you have done the stoma. If the purpose has been served, you can close it early. Okay, one of my PG was doing this thesis in SSKM, early stoma closure.
Okay, so patient is now well, you are planning to discharge, you have followed the ERAS protocol throughout. You have said that you are following the ERAS protocol. How do you know patient is fit for discharge now?
Sir, patient is tolerating diet. There is patient is febrile. Patient can mobilize.
No. There are 3 criteria in ERAS protocol for patient for discharge. One, you said rightly, is the patient is taking oral diet. Number 1. Number 2,
patient can ambulate.
Yes, patient is ambulant. That means patient could go to the toilet. Patient can take care of self. And third is
patient is febrile.
Pain-free.
Yes,
pain-free. So these are the 3 criteria in ERAS protocol for patient discharge. Patient should be pain-free, patient should be taking his oral diet, and patient is ambulant. That means patient can go to the toilet, patient can take care of himself. These are 3 criteria. Other things are there, but they are not in the criteria of discharge.
ঠিক আছে স্যার, আর কিছু কি ডিসকাস করার
না
দরকার?
ঠিক আছে, we have discussed. Lab we will discuss someday else. We will make a separate heading for lab earlier. Okay, thank you, Srilekha. Thank you, Dr. Jitiman. Thank you.
Thank you, sir.
Thank you.
কোনটা বলবো তো এই টাইম নিচে না
কিছু বললি?
ওকে বললাম না, তোমাকে বলি কোন ওষুধটা আমাকে বলবে তো।
ওই জল ওষুধ পারে।
দেখাও।
চলে যাবে, বিয়া চলে যাবে, চুক্তি চলে যাবে, সব চলে যাবে, ঘর খালি হয়ে যাবে।
রিয়া কুড়িয়া বেরোই
না, বিয়াটা কি কাজ পেয়েছে?
তুমি শিয়ালদা হয়ে যাবে আমার সাথে যেতে। কোন এই দুটো?
হ্যাঁ, এই দুটোই তো একসাথে মাখতে হবে।
রিয়া যদি এখন যায় যেতে পারে আমাদের সাথে, এক্ষুনি কিন্তু যেতে হবে। শিয়ালদা ছেড়ে দিতে পারি আমি।
তুইও যাচ্ছিস?
হ্যাঁ গাড়ি আসবে তো। ভালো তাহলে দেখি। আবার যাবে এক্ষুনি। রেডি হও, রেডি হও। ঠিক আছে। আসলে কোথায় কি জানো? হ্যাঁ, কত তুলবে তুমি? হ্যাঁ, 9টা বেজে গেছে। ঠিক আছে, তোমাকে বলেনি 9টায় আসতে? ভুলে গেলে হবে, হসপিটালের ব্যাপার, দাঁড়িয়ে আছে।
বেরিয়ে যাচ্ছে।
কি হয়েছে তোর? আস্তে আস্তে 10 মিনিট।
এদের 9:30 বেজে যাবে, ক্লাসটা শেষ হয়ে গেছে সবাই।
বারবার বলে দিলাম।
আচ্ছা,
রিয়াকে বলে দিচ্ছি যে 10 মিনিট লাগবে,
ওদিকে নিয়ে যাওনি? চলো, হ্যাঁ আমি চলে যাচ্ছি। তুই চলে যা, 10 মিনিট আসবে, দেরি হবে। গাড়ি আসছে, গাড়ি আসছে। বিস্কুট খাবো না, ওখানে বিস্কুট আছে। চল তুই দেখ, ওখানে এত বিস্কুট। কিসে যাবে তোমরা? কিসে যাবে তোরা? অটো, অটো। এখান থেকে অটো রিক্সা। চল। তাড়াতাড়ি তাড়াতাড়ি শুধু শুধু দুটো রিক্সা করবো কেন? ওই জন্যই বলছি। হ্যাঁ, তিনজনে একসাথে চলে যাবো। নেবে? হ্যাঁ, এই তোদের রিক্সা নিয়ে। চলো, আমার হয়ে গেছে, আমার রেডি।
ভালো ভালো রক্ত মানে রক্ত পরীক্ষা মানে পরীক্ষা করার মানে এককটা কি গো?
একক আবার কি, এক একটা যেটা পরীক্ষা করে সেটা এক একটা এক এক রকম ব্যাপার।
আমাদের পরীক্ষায় মানে রক্ত পরিমাপ করার এককের নাম বলে।
রক্ত তো লিটারে হবে, এমএল 500 ml রক্ত নিয়ে।
আমি লিখে দিয়েছি প্রেসার, লোকে বলে না ব্লাড প্রেসার, ওই প্রেসার লিখে দিয়েছি। আমি প্রেসার লিখে দিয়েছি। আর রক্ত এমএলএ মাপা হয় না?
ওখানে আবার আধার কার্ড বানাতে যাবো আর কি সব করবো। প্রচুর যাবে, ফাঁকা থাকে, বেশি ভিড় হয় না, ওখান থেকে তো সোজা, ওখান থেকে
আসছি কাকিমা।
আসছি রে, চলো। এটা সহজ কোশ্চেন পারেন গেল, জেমিন ডিগ্রিতে থাকছে। আমি বলেছি দুধে, একদিন বলছি তুমি আরেকটা সূর্যের আলো বলে দিচ্ছে, সূর্যের আলো দুধে মেরে বলি
সূর্যের আলোটাই মেন।
সূর্যের আলোটা মেরে।
সূর্যের আলোই ভিটামিন ডি, দুধে দুধে থাকে না। হ্যাঁ, আমার ওপিডি ক্লাস ছিল না, আমার ক্লাস শেষ হয়ে গেছে, ওকে আসতে গিয়ে তাড়াতাড়ি করেছিলাম, এখন পাচ্ছি।
ভালো তুমি জানি।
হ্যাঁ, এবার হচ্ছে কি, এটা ক্লাসটা অনলাইনে হয়তো সবাই জানে, বলছে এখন শেষ হয়ে গেছে, ঠিক আছে 15 মিনিট খাচ্ছ, রেডি হও, তারপরে আসছে।
হ্যাঁ একদম 4 নম্বরই থাকে।
এরপরে দেরি করলে তখন বলবে আস্তে কথা কি বলছে।
হ্যাঁ
বেরিয়ে অত আমার ভালো লাগছে, পুজোর কাজটা ঠিক করে করা।
লালু দেরি করে বলছি।
লালু না, লালু তো নেই,
ও লালু নেই?
লালু ছেড়ে দিয়েছে।
ও হ্যাঁ লালুর কথা বলছি।
নেবে যদি
হ্যাঁ আমি আসার সময় গড়িয়া হাত হয়ে আসছি। ওই বাসে করে
নাম দেওয়া থাকে। আমি তাহলে আসছি গড়িয়াহাট
না
ধান দিয়ে আছে।
হ্যাঁ
আমার দরকার নেই।
হয়ে যাবে।
এখানে পাঁচটা আছে
না ছোট তো,
হ্যাঁ এমনি করে তো